That is a great question. So usually requires a full consult to get through, but let me give you the quick and dirty on that. So the difference between a over the muscle breast augmentation is we create a space on top of the pec muscle behind the breast, kind of more of a natural place for the implant to be, versus under the muscle breast augmentation, we actually lift the pectoralis major muscle up and we create a pocket behind the muscle. Now, most people don't do a pure submuscular augmentation because the implant would become real tight and kind of trapped behind the muscle. So most of us do a dual plane technique, which looks a little bit more like this, where we cut the bottom of the muscle. That way the top of the muscle is going to be covering the top of the implant. The bottom of the implant is going to be more behind the breast. So we call it dual plane because it's in both planes. So what are the differences? Why would you do one or the other? Well, for most of my patients, I really kind of leave it up to them. I don't push one or the other. There's some doctors who are, everyone gets a submuscular dual plane augmentation. For a while, that was pretty popular. Everybody was doing that, but we're starting to see some problems, in my opinion, with everyone getting submuscular augmentations. So pros and cons. Let's start with under the muscle. So under the muscle, the big benefit is the muscle is there to provide additional coverage. It's going to do two things. One, if you're really thin or you got very little breast tissue, up here in the upper pole of the breast where you want to see all that cleavage, if you're over the muscle, you're only going to have a very thin layer of skin and subcutaneous fat, which means the implant's going to be close to the skin. And even though silicone implants don't typically cause all that much rippling versus saline implants, you could still see it. And no one wants to see that little scalloping or rippling coming through the skin. So that's one reason is in a very thin or a very small breasted patient. The other is the muscle is going to kind of create a little bit of additional softness and smooth the transition from the chest onto the breast. So in a way, it may give you a more natural look, but it depends on the individual patient. What are the downsides of breast augmentation under the muscle? The two big ones are, one, it hurts more. We have to cut the muscle gets stretched afterwards. That's why patients are sore afterwards. The other is the cleavage. So when we cut the muscle, we cut it along the bottom here, but we leave this part of the muscle attached to the sternum. And we have to do that. If we cut and release this muscle, what's going to happen is the implants will literally just be able to come together across the midline of the chest, which gives you what's called a uniboob. You don't want a uniboob, trust me. So to provide that, maintain that separation, we have to leave this muscle intact. The problem with that is, based on your anatomy, your muscles might insert on your sternum here, or they might insert on your sternum here. And if they're out here, you're going to have a big gap in between those breasts unless you're in a nice push-up bra to push them together. So that's one of the limitations, is we can't get the implants kind of as close together as we'd like to. The other one is animation deformity. So it's not common. Everybody gets a little bit of animation issue. The severe cases are less common, but it can be troublesome. So that's when the implant's under the muscle, and when you go to squeeze those pec muscles, they're going to compress the implant. The implant's going to want to move a little bit. In most women, it's very minor. The implant might just shift a little. You might see a little contraction of the muscle fibers. But in some women, they squeeze and those implants do some weird, crazy gymnastics underneath there, and it doesn't look attractive. And if it's severe enough, it might be a situation where you're in a bathing suit, you go to pick up your drink, and just from squeezing your pec muscle, picking up your drink, all of a sudden your implant's doing some crazy stuff. So people don't typically like that. So over the muscle. Now, over the muscle, the advantage there is that you don't have any animation issues whatsoever. We're not touching the muscle. It's less painful. And the cleavage can basically be put wherever you want because you are actually creating that pocket. Now, you have to be careful that you don't create the pockets too close because you, again, could get that uniboob problem. But you have the control to basically set that pocket where you want to on the chest. The disadvantage is kind of the opposite of the under the muscle, which is the implant's a little closer to the skin. So issues like rippling and visibility of the implant, or kind of having a more of a fake augmented look, are more possible. Now, the last thing that comes up is capsular contracture. So a while back, probably 20 years ago now, there was a study that showed that when they compared under the muscle to over the muscle breast augmentations, that the capsular contracture rate was twice as much in the over the muscle patients. So initially when that study came out, everybody freaked out, said, oh my God, we have to do everybody under the muscle. And it was a big reason why there was this big push from going over the muscle to under the muscle. And that's why a lot of doctors, especially ones a little bit older than me, probably that's all they're doing, because kind of they got started in their journey right when this data came out, and they've kind of stuck to that for all these years. When I came out in practice, we were starting to see some of the issues with under the muscle, and that's part of the reason why I just don't have a strong preference either way, and I kind of tailor it to the individual patient and what's going on with them. Some patients I say, you know what, under the muscle is going to be the best for you. Other patients I say, over the muscle is going to be the best for you. And I would say most patients I say, you know what, there's pros and cons to both. You decide which of those you would prefer. Go over it together and come up with the best plan. But I don't have a specific agenda to push on anybody. Now, the thing about that study was, yes, it did show double the capsular contracture rate, but sometimes information like that can be misleading. That sounds, oh my God, that's a lot, double, right? But the thing is, the numbers were small. So in the under the muscle category, I don't have the exact numbers, but it was roughly about 4 to 8% risk of capsular contracture in the time period that they studied. In the over the muscle category, it was more like 6 to 10 or 6 to 12% risk of capsular contracture. So of course, when you compare, you go to the extreme, you say, oh, well, under the muscle was 4%, over the muscle was 12%. Oh my gosh, it's 2 to 3 times more likely, right? Well, again, if you play with those numbers, you can make it sound really dramatic. But then again, yeah, 12% is not great. We'd like it to be as low as possible, but I mean, 12% is not the end of the world either, right? You have a 1 in 7 chance of getting breast cancer in your life. That's about 12% right there. So, so my point is, we got to look at the data with a grain of salt. That study hasn't really been repeated again on that scale to demonstrate if, in fact, that is, it's something that we can prove that under the muscle is more effective than over the muscle. The theory behind that was that capsular contracture, we think, is caused by some sort of bacterial contamination, right? And part of the theory was, well, if it's behind the muscle, the implant's not touching the breast, right? And if it's not touching the breast, then there's no way it's coming in communication with the ducts of the breast, because the ducts inside the breast actually communicate to the outside environment through the nipple. So technically, if you cut someone's breast open and you cut into the ducts, those ducts are not sterile. There could be bacteria hanging out in there because it's not a closed system. So the idea was, well, when you're over the muscle, the implant's sitting right behind the breast, somehow bacteria are making their way onto the implant and causing capsular contracture. But when it's under the muscle, that's not the case. The problem with that theory is, like I said earlier, most patients do a submuscular augmentation. A dual plane submuscular augmentation. And what that means is part of the implant's behind the muscle, but part of the implant is not. Part of the implant is behind the breast and touching the breast. So you haven't really eliminated that concern. So I think that argument is not probably accurate, but so why was the data skewed that way? Don't know. Love to have that repeated in today's current time with today's current implants and the technology we use. We have things like the Keller funnel, which we use. Most of us use a no-touch technique, and all kinds of different things that we do in surgery to try to eliminate this potential bacterial contamination that we think is causing capsular contracture. So, in a nutshell, over the muscle, under the muscle, it's going to depend on you, what you want. And, that's the reason that we like to talk to people in person and have a consultation, and we can go over all these things in your specific case of what's going on with you versus, everybody just wants to call up on the phone. How much is your breast dog? And, when can I get in? And blah, blah, blah. This is the reason doctors want to talk to you, okay? Because we want to give you all the information, and we want it to pertain to you and your specific situation. So hopefully this was somewhat educational, and this helps you make a decision regardless of what plastic surgeon you use for your breast augmentation. But that's kind of the way I give my spiel to patients. And if you come in to see me, you basically already had your consult, right? So you'll just be hearing me regurgitate this all over again. So, all right, well, if you all have any more questions about anything related to plastic surgery, let me know.